Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Dr. Ben Weitz here. Thank you so much for joining me again today. For those of you who enjoy listening to the podcast, please go to Apple Podcasts and give us a ratings and review. If you'd like to see a video version, go to my YouTube page. And if you go to my website, drweitz.com, you can find detailed show notes and a complete transcript. So today our topic is Lipoprotein A with Dr. Joel Kahn. So we're going to talk with integrative cardiologist Dr. Joel Kahn about a very specialized factor that increases your risk of heart disease. This is a specialized lipid particle that is not often measured, but can be seen on a specific blood test. We've all heard about cholesterol as a major risk factor for heart disease. Most of us have also heard about LDL, the so-called bad cholesterol, and HDL, the so-called good cholesterol, and you may have even heard about triglycerides, but you likely have not heard about this specific particle, and it's unlikely that your primary medical doctor or cardiologist has even measured it. The conventional medical way to think about lipoprotein A is that it's determined by genetics, and there's no prescription drug that can lower it, so what's the point of measuring it? At least that's what I've been told by some primary care doctors and conventional cardiologists. But from a functional medicine perspective, from an integrative perspective, there are some natural strategies that can lower lipoprotein A, and it's very important to know if you have this risk factor. We've known for years that a sizable percentage of patients who have heart attacks actually have normal cholesterol. So there must be some other that's that account for why they have this heart attack, and lipoprotein A is one such factor. There's a famous example that's been in the news a few years ago. One of the trainers from The Biggest Loser, Bob Harper, who was in incredible shape, and yet he had a massive heart attack and almost died. And he had essentially normal risk factors, normal cholesterol, but he had very high LP little a lipoprotein levels. And so elevated levels of lipoprotein A increases the risk for coronary artery disease, heart attack, stroke, thickening of the aortic valve, and even heart failure. Dr. Joel Kahn is an integrative holistic cardiologist, internationally known speaker, and best-selling author. He has a very popular weekly podcast, Heart Doc VIP, that I listen to regularly. And he's written 6 books, at least 6, including Your Whole Heart Solution, Dead Execs Don't Get Bonuses, The No BS Vegan Sex, The Plant-Based Solution, Young at Heart by Design, and his newest book, an Amazon bestseller, Lipoprotein A, The Heart's Quiet Killer. Dr. Kahn, thank you so much for joining me today.
Oh, you need ice cold water for all that incredible, kind, both very appropriate introduction and then the kind words. I was on a podcast recently as a guest, and I did write a book called Dead Execs Don't Get Bonuses: How to Survive Your Career with LDR. But I was introduced as the author of Dead Exes Don't Get Bonuses, which if I write a divorce book would also be appropriate. So you nailed it, buddy.
I remember the golfer John Daly wrote a song called All My Exes Have Rolexes.
Oh, that's pretty funny. A little play on Willie Nelson there. Good deal.
So what is lipoprotein A?
And this is authentically, I'm so happy to share this with your audience. It's nothing about me. It's about their health, your health, our ability to make a dent in the number one killer of men and women in the United States. That rolls off your tongue. Number one killer of men and women. That means 39-year-olds die of heart attacks, and 44-year-olds have bypass, and 51-year-olds have stroke. And we're also going to talk about a valve in the heart called the aortic valve, which doesn't get as much press, but creates a couple 100,000 procedures that some people make it through and some people have complications. So it's just what you said. We learned way back in the 1960s. Why would I go there? If you smoke, do you have diabetes? Do you have high blood pressure? Do you have high cholesterol? Do you have a mother, father, sister, brother with an early heart attack, early death from heart disease? These so-called Framingham risk factors. Your doctor sits down with you and might pull out a little app on the phone, on their laptop. Hey, you're in really good shape. You know, your numbers, your history, you're at low risk. That does help us define a one-to-one patient. You know, are you really a high-risk patient or low-risk patient? Do you need medications? Do you need lifestyle? If you do your best job at that, it's still missing about 40% of the people that go on to have heart attack, strokes, drop dead, or in this case also aortic valve surgery. That is called residual risk. Just as you said, we should care about, you know, identifying 50 to 60% of the explanation. You're a root cause guy. I'm a root cause guy. Your cholesterol, your blood pressure, your blood sugar's up. It's not just a prescription. It's diet, fitness, stress, environment, you know, chronic infection, toxicity, and all the rest. We should be searching. Why don't we reach more than 50, 60% of explaining heart disease? Lo and behold, 57 years ago, 1963, a Scandinavian researcher found a new cholesterol particle in the blood. And now there's several thousand research papers, and we know which gene, and we know what RNA, and, you know, we've characterized it completely. And it got the name. It's not a good name. That's the biggest problem. You know, it's like the Pinto, if you go back long enough for a Ford car, it never was a good name. Name a car after a bean. But this was named lipoprotein little a. You know, some people call it the sticky cholesterol. Can you imagine if all the research called it the sticky cholesterol? I mean, that has Madison Avenue, you know, attraction, because we just got to get it unstuck. But what we've learned, I'll be brief, is you go to your doctor, you have your annual physical, you go to a wellness fair, you go to a corporate wellness fair at your business, you get your finger poked or a full blood draw, and your doctor says cholesterol, HDL, LDL, triglycerides, blood sugar, blood pressure, all those things. They're great to know, but they did not measure this cholesterol particle that was found 57 years ago, although it is simply a blood test. You can't do it, as far as I know, from a finger poke. Any lab, Quest Lab, LabCorp, any hospital in LA, anywhere, for about $30. So what have we learned? We have learned that this cholesterol particle does three things that are just awful. It causes atherosclerosis. It actually may be found in the plaque that closes your carotid artery, your heart artery, your sexual organs, your kidney arteries, leg arteries. It may be found in the plaque more than the one we talk about a lot, LDL cholesterol. There's a reason, I'll tell you in a minute. So it causes plaque. That's bad. Plaque causes people to lose quality of life and quantity of life. Number two, it causes inflammation. It has some really unusual attachments called oxidized phospholipids. You teach your patients about inflammation as a root cause of many chronic diseases. This particle is pro-inflammatory. And the third thing so unique is it actually promotes clotting of the blood. It's prothrombotic. Even LDL cholesterol doesn't do all that. Some people have said, imagine LDL cholesterol has cholesterol in the middle, has some things called phospholipids on the outside, and then it has, it's called apolipoprotein B. It's something you can measure in the blood. I don't want to get too technical. People say it's like LDL is like a baseball, and apolipoprotein B is the stitching holding it all together so it can float through the blood, either back to the liver, on its way to tissues, on its way to arteries. Lipoprotein A has the LDL, then it has a little, it's called two sulfurs, a little bridge, and then it's got this unique tail. And people say, imagine a baseball the pitcher is throwing at you with huge spikes all over the place. God forbid, you get hit by that sucker, you're going to have a lot of damage. That's just an analogy. But that's the difference between, LDL, which is already a problem if you have it in excess, potentially, getting under your arteries, responding, it's called, to retention of the cholesterol in your arteries to drive a plaque. But now we got these spikes all over the place. So lipoprotein A is a nasty little beast. And this is the magic. You said the word genetic. Okay, I learned when I was a cardiology fellow in Dallas, where a Nobel Prize in Medicine was awarded to two of my professors right when I was there about LDL cholesterol and the pathways. 1 in 500 people, maybe 1 in 250, from their parents inherit a high LDL cholesterol purely on genetic. Eat sprouts, go to the gym, be thin, still got a cholesterol of 400, that's genetic. Turns out this lipoprotein A, the new kid on the block in terms of what most people know about, 1 out of every 4 people, not 1 out of every 250 or 1 out of every 500. That means right now, how many people are listening to this, very valuable podcast? 1 out of every 4, you got it, you got it, you got it, you got it. It's a lot of people. It's 90 million Americans. And those 90 million Americans from the time they're 1 year old have this triple threat particle in the blood, and slowly, they might, it's not inevitable, like these risk factors, you can have a high cholesterol and not end up with a heart attack, but you're at risk. You end up about 2 to 4 times more likely, stroke, heart attack, valve scarring, the aortic valve gets scarred and you need heart valve procedure. And doctors scratch your head and say, Bob, Sue, why'd you have a heart attack? Your numbers look so good, your lifestyle, your diet, Mr. Jones, you just had your heart valve out. We have no idea why you developed this problem, but we've taken care of it. Well, it turns out very frequently it's lipoprotein little a that drives all this. So that's the broad picture. Would you want to know that you inherited 1 out of every 4 people? It could be one parent. You could get the double jeopardy of both parents. On chromosome 6, there's a gene in 1 out of every 4 people. And there's a whole lot of discussion. Why do we have it? When did we get it? What can we do about it? But it will become in the next 5 years routine. You're hearing it now early, 5 years from now, there'll be an expensive drug that the pharmaceutical industry will be sure every healthcare provider in America knows to check lipoprotein A. They do it in Europe, but God bless America, great country. We're sometimes a little slow to adapt new science, like 57 years.
How about adding this to the risk factors? Here we are in the midst of the coronavirus pandemic, which causes clotting. What's the likelihood that somebody with elevated elevated lipoprotein A, if they get coronavirus, is liable to have a worse prognosis?
Well, you are like a visionary. So that is a theory. There's very few people in the country that are studying lipoprotein little a. There are, but there's not a lot. And some of them have brought up this question. Could it be if you're at UCLA or you're at USC and you're sick in the ICU, like Broadway actor Nick Cordero has been in the news in Los Angeles, 39 years old, and he's still 90 days later. Clotting has taken one of his legs, and I hope that God doesn't take his life. Could it be, since it's 1 out of every 4, that ICU bed, that one, no clotting, clotting here? It's been hypothesized that it could be. Somebody needs to draw the blood and run the numbers and see if it correlates and tries to explain this monster problem in COVID-19 of apparently blood vessel damage and clotting, which is a real deal. But so it's become even more in the focus of the media to some degree, the science community to some degree. But we got to get the word out, and then we can play with it. Let me talk about the clotting for a minute, because it's a question. Why do we have things in the blood that seem to be all a disadvantage? I mean, what is the reason? So.
Right. It's got to be an evolutionary advantage if it's there.
And so it turns out the only species on the planet that have the ability to make lipoprotein A in the liver, it's not made like LDL. That is made in the liver. This is a whole different factory. GM and Ford, totally different. That about 40 million years ago, we may have developed the ability, 1 out of every 4 people, to produce lipoprotein A. Well, why would we do that? This is a little complex, but it's really interesting. And it's going to fit with your emphasis on nutrition for sure. That also about 40 million years ago, humans lost the ability to make vitamin C. And very few people know that your dog and your cat make vitamin C, whatever amount they need, from glucose. Actually, glucose can be converted to vitamin C. Humans lost the enzyme. It's believed maybe we were in the jungle and eating so many leafy greens and fruits and such that we just didn't need an enzyme pathway anymore. And maybe there was an advantage that whoever lost that gene had some superpower that evolutionary favored their survival. Dr. Linus Pauling, who won 2 Nobel Prizes, and to some people, they immediately would say the vitamin C guy. Yes, he's passed away, but he was the vitamin C guy. He hypothesized when we lost the ability to make vitamin C, if you had the gene for lipoprotein A, you had an advantage. Let me just run you through this. If you're deficient in vitamin C, you can develop scurvy, and you're going to bleed in your skin and your gums because your collagen and your tissues are super weak, including your arteries. Well, it turns out lipoprotein A tries to prevent breaking down clots. So if you have weak arteries 40 million years ago from scurvy or something close to scurvy, it might be an advantage to have lipoprotein A when you have a baby, when you got cut, chasing a saber-toothed tiger, if that's the right term. I haven't said that word in a while. It might have been an advantage in terms of excess bleeding by favoring clotting. It is similar to something in our body called plasminogen. Plasminogen breaks down clots. Here's a competitor that interrupts that process. Very complex idea to think about it, but it's interesting. And when you talk COVID-19, all of a sudden, it might just be the factor that's a disadvantage by promoting clotting and not allowing breakdown of clots. Interesting theory. More, traditionally, it's an issue with just clogging your arteries. And if you have carotid surgery and you take the plaque and look at it under a microscope, you can find a ton of lipoprotein little a structures in the plaque. Same with if you have bypass surgery and they take out some of the tissue of the heart arteries and look at them. A very dense concentration. So it's in the plaque. It's not some window dressing. It gets under the endothelium. It gets retained. It causes inflammation and foam cells and plaque. And it does it on a heart valve too, which is really unusual. 1 out of every 7 aortic valve surgeries in the United States are believed to be due to the constant, from the time you're 1 year old, irritation, inflammation, and thickening of the valve from lipoprotein little a. So it's just a monster to deal with clinically that we haven't even addressed really.
So when you see it on a lab, what level do you consider significant? A couple of the labs that we typically use usually say anything over 30 milligrams per deciliter. But I've seen some people say 50. I've heard other people say, well, it should be as low as possible.
Right. So it turns out, and I want to stress this again, this is just a lab test. This is $30. We're not talking about needing to have a bone marrow biopsy to determine this.
Right.
Tomorrow at your doctor, you can have your blood drawn for this, or at any lab. There's 2 ways, unfortunately, like pounds and kilograms. They both describe your weight. There is a unit, milligrams per deciliter. Less than 30 is normal, and over 50, just an arbitrary cutoff, is felt to be the higher risk group. But that can go 50 milligram, 100 milligram per deciliter, 200, 300, 400, 500. I've got patients in my practice that are 400, 500 plus. Not much more than that. You're not going to see 1,000. And again, 1 out of 4 is over 30, but a substantial number is over 50, 60, 70, 80, I think. But 2-3% of people are over 100. There is another unit called nanomoles per liter. Quest Lab now reports in nanomoles per liter. A lot of other labs report. It doesn't really matter. The normal range there is less than 75 is normal. Over 125 is considered high risk. They're pretty similar, and I think pretty soon we'll stop doing the milligrams per deciliter. But again, there's no real issue about one more accurate than the other or ignore one. Pay attention either way it's measured. Simple lab test.
So if a patient has a elevated LP little a, how do you work them up to see if they're having any negative effects from it?
Right. So for, the past 10 years, if you do find lipoprotein little a mentioned in a guideline, the American Heart Association might come out with something about prevention, the National Lipid Association, a group that really deals with complex pharmacology and pathophysiology. They might tell you if your family history is strong for early heart attack, early stroke, early valve problems, calcified aortic valve, ask your doctor. It's reasonable to measure the lipoprotein little a. Again, blood test has been available for over a couple of decades, but not a routine test. has been recommended. That's starting to change in November 2019, so pretty recently. In Europe, it's called the European Society of Cardiology, their equivalent. They came out with a new guideline that said, we now believe it's prime time. Everybody once should have the level measured. If you're normal, you don't need it again. You don't have the genes that are actively producing lipoprotein A. And if you're elevated, well, it fits in the risk factor profile and may explain some of this risk that your standard approach hasn't identified. So the workup is take out of the stethoscope if you have one as a healthcare provider. Make sure there's no murmur from the aortic valve. Make sure there's no noise in the neck called a bruit, and make sure they're not describing anything that suggests blockage like shortness of breath or chest tightness or chest pressure. Look at the other numbers: blood pressure, blood sugar, weight, waist circumference, inflammation, maybe homocysteine, and the cholesterol panel. My approach, I think it's consistent with the general approaches. If you're 40, 45 and you're really a health-seeking individual and now you've checked your lipoprotein A and it's abnormal, you might want to get a heart calcium CT scan. You have no symptoms. That's a quick 5-second CT scan that costs about $100 at UCLA, at Cedars-Sinai, at Good Sam, some of the best places in America where they're done. No injection, no IV, and it takes a quick look at your heart arteries. And if it comes back really good and your blood pressure is good and your other numbers are good, okay, you've got a risk factor. Eat a little better, exercise a little more, and do the whole program of heart disease prevention with maybe a little more incentive to really do it well because you identified it. If you knew you were prone to kidney cancer, if you knew you were prone to breast cancer, there's some measures. You might not be going to Arby's and McDonald's every day. So lipoprotein A to me is a good platform just to get people on a good place. But if there is known disease, doc, I had a stent last year and nobody checked my lipoprotein A, and now you're telling me it's 300 milligrams per deciliter. Or if they're silent, but by calcium scoring or a murmur, you identify there's a disease process that isn't yet overt. There's room to consider what do you do about it. And before we talk about that, you always treat all the other stuff. You want your blood pressure to be at its best. Use all the approaches, standard and natural, from yoga to acupuncture to breathing to sleep, and the whole thing that your audience knows so well from your good work. You want your cholesterol to be in range, and do it with diet. You want your blood sugar, but do you specifically address the lipoprotein A? And in 2020, there's sort of a divergence of opinion, and tell you the standard opinion is use it as a risk factor, but there's no way to deal with it, just as you said at the beginning of the podcast. I disagree with that, but that's the standard approach.
So why don't we start with the nutritional supplement approach?
Sure. Thank you. And let me just say what doesn't work.
Okay.
Take it right off the table. Lipitor, Zocor, Crestor, the statins, which your doctor is going to ask you to consider taking if your cholesterol is very high, and certainly if you've had an event like a stent. They do not lower, again, the production of lipoprotein A in the liver is totally different than LDL cholesterol. Your LDL cholesterol will fall with a statin, almost always, but it actually doesn't address lipoprotein A, and it sometimes raises it. That's the disconcerting part. Doc, my lipoprotein A was 180 milligrams per deciliter. We went on Crestor, and you just told me it's up to 270. I've seen that dozens of times. Now, some would say don't recheck it. The reason you started Crestor was to lower the LDL, lower the C-reactive protein, be consistent with a lot of studies in somebody with known heart disease. But don't expect your lipoprotein A to go down. So that's, the main prescription drug. Back to natural. There's been an adequate number of studies to look at some issues. Coenzyme Q10, a great heart supplement, it goes down a little. Ground flaxseed might go down a little. 5%, 10%, nothing substantial. And nothing in the range that's really felt to really move the needle a lot in terms of better outcome. There are no large long-term studies. There is the supplement you're well aware of, L-carnitine. That is in a lot of energy drinks, even it's in Red Bull or Monster, but that's not where I prefer a patient to be getting their L-carnitine. It obviously comes from red meat, the carne of carnitine. But you can take a capsule or a powder with L-carnitine. You might drop your lipoprotein 20, 25%, a little more substantial. If a woman's perimenopausal and chooses to go on hormone replacement therapy, lipoprotein A tends to go up a little at menopause, and it'll come back down maybe substantially with hormone replacement therapy, if they find a practitioner that does that. The big one, though, is niacin. Niacin, plain old, $10 a month, get a big red hot flush face from taking vitamin B3. Will lower LDL cholesterol, nice. Will raise HDL cholesterol often. We think that's good, we don't know. Will lower triglycerides, nice. Will lower overall cholesterol, but it actually can lower lipoprotein A pretty predictably and variably 20% to 80%. So you can sometimes, if you choose to use niacin, you got to tell a patient about the flushing, about rash, about watching your blood sugar, your blood enzymes, gout. But it's been around for 50, 60 years. You can buy a big bottle of good natural niacin for $30 to last 3, 4, 5 months. So it's not been studied, though. I mean, the big drawback from the academics, like if you go 90 miles south where you live, at UCSD is the leading academic physician. And he won't publicly blast out, use niacin, because where's the 1,000-patient, 10-year study that identifies you just drop that person's risk of heart attack and stroke? Privately, and in certain publications, he uses niacin too, because we know it's on a limited range of therapeutics. It works. And now there's new stuff. We can talk about that 1 second.
Yeah, the average primary care doctor, who doesn't really study this stuff a lot, who's not really up on supplements, the few things they've seen about niacin is, niacin doesn't work. It might even be harmful. Forget it. So they basically have a negative view of niacin, but that's because of a couple of studies that weren't really valid, right? Yeah,
the idea of people that had almost normal lipids trying to raise the HDL, called the AIM-HIGH study, and another study with a very odd form of niacin that had a combination drug. Right. So, for many years we used just plain old niacin or prescription niacin and saw good results in the blood work and had reason to believe we saw some benefits in the artery. But never has there been a substantial study, 100 people, 500 people. So it's untested. Now, problem is niacin's cheap and niacin's generic. Right. Who's going to come up with $80 million to do a 3-year study looking at carotid arteries and all? So it's a hot potato. The exciting news, but it's not.
By the way, what dosage do you find on the niacin? Do you get results with 500? How much do you have to take?
I will start a person, and I'll say the name of a brand. It's not my company. I use a over-the-counter brand called Enduracin, Enduracin. It's been used for decades. It's inexpensive. And I will start 500 twice a day, warning the patient about flushes, rash. Take niacin with applesauce, you don't get as much a rash, or with a non-fat yogurt. Like typically, they don't complain that much. But I will try and work them up based on labs to 1,500, maybe 500 in the morning, 1,000 at night, often to 1,000 and 1,000. You can go higher, 3,000, 4,000, but you really got to watch that patient. The flush isn't bad. I mean, I take niacin a lot just kind of for the fun of it.
Yeah, the apple contains quercetin, and that's what's believed to help counter the flush. So you might be taking quercetin now as part of your immunity program, so you can probably...
That's a study Merck should have done. They did niacin with a novel prostaglandin inhibitor, and the study gave niacin a bad name. They should have done the niacin with applesauce study, and we would have probably been much more optimistic. Right. Now, just recently, I don't know, 5 years, there's been a growing emphasis. We need a pharmacologic approach. I will say, exercise, please. If your lipoprotein A is found to be high, exercise. It'll improve all your other risk factors. It doesn't do much to move lipoprotein A down. You can drop your cholesterol substantially with exercise and weight loss. There's one distressing study. If you lose weight, your lipoprotein A goes up. Oh, my God. But exercise anyways. There's a 2018 study that a whole food plant diet, healthy, bright color, may lower lipoprotein A, but it was a modest amount. It's not the kind we expect with.
In your book, you mentioned coffee.
Yeah, coffee a little bit. It can lower it. So there's a lot of reasons to drink coffee rather than Coca-Cola or Mountain Dew.
That could be the new marketing campaign for Starbucks, right. You know?
Coffee for your lipoprotein A. We maybe could put niacin in coffee beans and maybe corner the market. But a little company called Axia came up with something called a antisense oligonucleotide, ASO. I mean, this is not a word we say too often. But as the gene for lipoprotein A produces RNA, this thing binds and mimics what should happen normally to stop so you don't make lipoprotein A. It's an antisense oligonucleotide. It's actually an injectable once-a-week product, and about 280 people with high lipoprotein A and some sort of vascular disease completed a study published late 2019. Very little side effect injecting this once a week, and about an 80% drop in lipoprotein A. The company was, I'm not sure if bought or merged with Novartis, one of the giant pharmaceutical houses. And so this spring, there was supposed to be a 7,600 patient study. Moving forward now, placebo, the same drug, high lipoprotein A, vascular disease, because you can't get FDA approval nowadays. Not dropping lipoprotein A doesn't get you FDA approval. You got to show heart attack, stroke, safety measures, and all the rest. With COVID-19, I'm sure recruitment and follow-up has been, very, very difficult. So we can only hope they can get that study really quickly going and enrolled. So by 2024, that was the original estimate, we'll get some data. I'll say two others actually, to be thorough, because your audience is sophisticated. There is a very bizarre therapy. You inherited the other kind of genetic cholesterol. Your cholesterol is 700, and at 32 years old, you had a stent. There are people out there, 1 in 250, 1 in 500. And it may be very difficult to get your cholesterol down with Lipitor and other drugs on the market. There's a procedure that's like dialysis. It's called lipophoresis. They stick a needle in your vein. They take blood out for 2-3 hours. It filters, but the filter doesn't get rid of kidney products. The filter gets rid of cholesterol. Your plasma goes back in your body. 3 hours later, you got a Band-Aid, you go home, and 2 weeks later, you come back and do it again. So your LDL cholesterol, if you have that problem, can fall 95% in 3 hours, and it'll slowly go back up and do it again. That has been shown in the United States and Europe, and it's insurance covered for the right person to decrease your risk of heart attack, stroke, and all the important measures. It's also approved for lipoprotein A. Very few places do it. Germany is a hotbed. They got thousands of people with cholesterol disorders that use that approach. And you might find at the Cleveland Clinic and at perhaps UCLA or Cedars-Sinai, you'll find 1 or 2 programs in a state if they're a densely populated state. Lastly, there's an injectable cholesterol drug that is FDA approved called Repatha and Praluent. It turns out they're very powerful at lowering LDL cholesterol, but they modestly lower lipoprotein a. They're just not approved for that. So if I submit to insurance, my patient Charlie needs to get his LPA down, and I want to use, that's the other name for lipoprotein A, LPA. I want to use Repatha at $6,000 a year. They'll tell me that's not appropriate. We can only use it to treat LDL cholesterol. So, you work around that and hope to get a patient on that if they meet the criteria.
Right. And then there's the Linus Pauling thing, right? With vitamin C
so
and
good
lysine.
to mention that. Yeah, which goes back to what we said 40 million years ago. We're dependent on vitamin C exogenously. That's called food usually, because our collagen production is dependent on intake of vitamin C. So he hypothesized, he wrote an article in 1990, and he died in 1994. He was like 95 years old. So he's 91 years old writing original research. I think this lipoprotein A vitamin C thing is real. And if people would just take in more vitamin C and lysine, the 2 essential components to make strong collagen, then this lipoprotein A thing would be like neutralized. It would circulate in the blood, but it wouldn't be able to actually harm arteries. That was a theory till 2015 when his protege, a guy named Matthias Rath, did a mouse study. And the mouse study confirmed the theory. There's still no human data. What's the bottom line? I have a lot of patients with high lipoprotein A. What's the harm to taking 2, 3, 4, 5 grams of vitamin C powder or capsules? Certainly to eat the foods rich in vitamin C. And what's the harm to add 1,500 milligrams a day of lysine as a powder or capsule? But you won't see the blood level necessarily go down. There really isn't a way objectively to monitor it. So I can tell my patients it's faith-based therapy. It's until the definitive study is done that shows we've blocked lipoprotein A from being the sticky cholesterol. That's the idea. It makes it not so sticky to your arteries. Cool stuff.
Yeah, I think you mentioned low-dose aspirin as well.
Well, because of the vascular risk, you might argue you could talk about nattokinase, lumbrokinase.
I was just going to suggest that.
But there has been a study suggesting in a high lipoprotein A patient, and certainly if you have an abnormal calcium score, or if you find a center that does carotid ultrasound with a reasonable, if you have plaque, you're probably going to want to be on an 81 milligram aspirin anyways.
Right. Yeah. I saw an article that showed EPA from fish oil had some benefit as well.
Yeah, that's the problem. Other than niacin, carnitine, modest, HRT, hormone replacement, modest, CoQ10, flaxseed, and omega-3, really modest. There's been an estimate that you really need to drop lipoprotein A, something like 50 to 60%. It was a modeling thing to expect that you're going to see, a significant drop in events. So, it's important to get to that point. The future is some sort of gene editing, and I'm not a world expert on gene editing. There's a new company out called Verve Therapeutics. Bright people and a lot of money right now on it. And they just announced in an animal model that they were able to cut out and turn off an LDL cholesterol gene and a triglyceride gene and successfully drop blood levels of those, markers, provocateurs of vascular disease significantly. Nobody's yet got to that point to do it for the lipoprotein A, but with 90 million people in this country alone, somebody's going to get hot on the trail of, finding how to do that. So, that may be the next 5 to 10 years. It's just very hopeful. It raises all the questions. You're a 54-year-old man or woman at your doctor and they tell you your lipoprotein A is high. What do you say to your 25-year-old kids? Because there's a chance your spouse may or may not have lipoprotein A as a genetic inheritance. But your kids may or may not. I mean, should they know at age 20, 25 that their smoking habit is double jeopardy and their cheeseburger habit is double jeopardy? I would argue, why wouldn't you want to be fair with the data and, not scare, but, it's educate. American Heart has something called the Simple 7. Well, it should be the Simple 8, do a little bit more if you've inherited lipoprotein A. It doesn't have to be the scariest conversation in the world. Yeah,
everybody thinks it thinks about heart disease for people in their 50s and 60s, right. But they've done autopsies on 17, 18-year-olds, like I think in Vietnam, and a lot of them had atherosclerosis that had already started then. So this is a long-term process.
Very slow, progressive deterioration in blood vessels that is detectable in your teens, 20s, and 30s, but we just don't have a system that encourages that. So, yeah, I would want my kids to know. I happen to have had. You really only need the blood test once, and if you're normal, you're done. And I'm normal, and my wife's normal, so our kids are not going to have a high level. Assuming they're my kids, you never can really be sure. But if it was a different situation, I would want them to know. Just the BRCA gene. A lot of conversation about that, and we're getting a little better at measuring pancreatic cancer genes and other disease states. You can tailor your life a little bit in favor of avoiding the disease.
Right. Great. So I think that pretty much wraps it.
Yeah, I'm trying to think if there's any
we talked about diet a little bit, right? Anything else about diet?
No, there was originally a paper 20 years ago that I don't want to get into diet wars. There's a bunch of ways to eat poorly, and there's a bunch of ways to eat in a healthier pattern. There was a study some 20 years ago that a higher saturated fat diet may lower lipoprotein A. It was also modest. Subsequent studies haven't confirmed it. In fact, there's an acute feeding study. Take humans, measure their lipoprotein A for 6 hours. When you feed them a diet high, specifically, it's called palmitic acid and stearic acid, the long-chain saturated fatty acids found in meat and animal products. You really got a spike in lipoprotein A. It actually has a little bit of cool studies have been done that, and this gets into why we have it in our blood. If I take you to the cath lab and do an angioplasty and stent on you, which is part of my history and training, and you measure lipoprotein A for a few hours, it spikes up for a while and then it falls back to baseline. It has called an acute phase reactive. And the idea there is perhaps we don't want clot to form, that it's fighting with plasminogen. It's kind of reacting to this activated balance of clotting and unclotting, clotting and unclotting. So, I mean, there are some little neat factors in some of the studies that have come up. But I just want to emphasize again, the biggest challenge will be your listener has a annual physical scheduled next week after July 4th or after middle of July, whatever it is, goes to the doctor and says, I heard this really interesting podcast and I want you to check my blood. And the doctor's going to say, I don't think our lab does it. I've never really heard about it. Because doctors who've been in practice for a while are smart and wonderful and good, meaning people by and large for sure. But no pharmaceutical reps coming by right now, no grand rounds lectures coming by right now. It's in the medical literature. Anybody can just go look it up. There is a nice site, lipoproteinAfoundation.org.
Yeah, I looked at it.
A woman who had a heart event in her 30s. I love people that take their personal, problems and turn them into a passion to help others. And the woman that's behind Lipoprotein A Foundation is one of those women. It could be a man, but everyone I know who's done it is a woman. And it's a very informative website. It's a little conservative. They don't encourage niacin. They're waiting for definitive trials. Their board of academic advisors are good academic doctors that like to see big outcome studies, and I honor that. But real people right now are challenged by their levels, and so one-on-one, you can be a little bit creative with people.
Right. And then we talked about exercise, right? Exercise obviously is beneficial for anything related to lipids.
You better believe it. Change particle size and particle number, and insulin resistance goes away. And you got to, you can't depend on some pharmacology that might come down the road in 4 to 5 years. So you got to, do the hard work. But,
Right.
Consistently we see over and over the lifestyle, the avoidance of smoking, the regular fitness, the real food diet, the emphasis on sleep, stress management, optimal weight is the pathway that has been shown recently to help prevent Alzheimer's disease, type 2 diabetes, inflammatory diseases, and it's the heart program. I mean, the body reacts, oxidative stress and inflammation.
Yeah.
It can damage all organs, or if you play your cards right and do the hard work, it can avoid damaging all our organs.
Excellent. So how can listeners get a hold of you, find out about your book?
Yeah, the book's on all the online sellers. Of course, it did spend March as the #1 heart book on Amazon, which is always a treat because I didn't have a whole big press team behind me. It just tried to blab about it some because I really want people to know about it. I'm at drjoelkahn.com, drjoelkahn.com, and I see patients and I do a lot of interviews, and I have a podcast. And like you said, it was very kind to give me a shout out. But I just like to educate, and like you, if I'm going to educate, you got to read, you got to study, you got to learn. So it's the best of medical practice when you're fired up about bringing people new stuff. So you do such a great job at that, and I appreciate you letting me share this time with you.
Absolutely, and I thank you for joining me today. So,
what's the other thing we learned today? Don't wear a gingham check shirt on an interview, because I started with that before we went live, and it looked like some kind of electric Kool-Aid 1960s experimentation. So I peeled down to a simple green shirt. So
I was listening to one of your recent podcasts, and you were talking about fish oil and how some people have kind of been maligning fish oil because there was a couple of studies that maybe fish oil might lead to prostate cancer risk.
Right. But, nutrition science is tough.
It turns out that both of those studies that were authored by Brasky,
right,
both of them were based on levels of DHA and EPA in the blood. Neither study were patients given fish oil.
Right. So that is an issue. You can see a meta-analysis that included people that got 100 milligrams of EPA DHA in the same database that got 2,000 milligrams, which is probably a much more reasonable and therapeutic level, but you lump them all together and you dilute out the good studies with studies that may have been, dramatically underdosed, and who's the group you're studying, it goes on and on. So that's the challenge. That's why once in a while the Cochrane database will come out with a statement that most people feel is of higher quality on a nutrition topic. And no one study changes everything forever.
Of course, absolutely.
With very rare exception. You just got to put it all together and, say, where does this fit in the big picture?
Exactly. Awesome, Joel.
Thank you.
Thank you. Talk to you soon.
Stay healthy. Have a wonderful summer.